Treating head and neck cancer creates a direct physical paradox. The very structures a patient needs to chew, swallow, and stay alive are the same ones oncologists must target with localized radiation and chemical therapies. The collateral damage from these therapies injures delicate mucosal tissues, compounding the weight loss already driven by the tumor. This creates a severe threat to a patient's ability to tolerate their prescribed treatment. Standard clinical nutrition often fails here. Dumping liquid calories and passive protein into a body overwhelmed by systemic inflammation is biologically inefficient. In this clinical setting, starvation acts as an active antagonist. When physical decline becomes too severe, the medical team is often forced to pause the life-saving treatment itself. To address this, researchers are utilizing an intervention called immunonutrition. This approach utilizes high, targeted doses of specific nutrients like glutamine, arginine, and omega-3 fatty acids. This animation shows the mechanical difference between the two approaches. While standard calorie spheres often bounce off an inflamed cellular barrier, these immunonutrients are formulated to cross that threshold by modulating inflammatory pathways. They function as an active biological shield. To see if this theory holds up at the bedside, we are auditing a systematic review of 10 years of clinical data, encompassing 20 independent studies and over 1,500 patients. We are measuring the actual clinical impact against the theoretical promise to see if immunonutrition truly changes patient outcomes. The clearest signal in the entire 10-year dataset emerges in the category of nutritional status, specifically weight preservation, BMI, and overall nutritional risk. The trajectory of weight over time tells the story. Standard care sees patients drop into the red. Those receiving enriched formulas maintain stable mass in the green zone. 5 of 7 studies confirmed stabilization when administered continuously throughout radiotherapy. Structured immunonutrition effectively blunts the severe physical deterioration that otherwise occurs during heavy radiation and chemotherapy. Moving to localized tissue damage, we must look at the radiation-induced mouth sores, known as mucositis. On the left, total incidence shows glutamine doesn't prevent mouth sores from forming. The overall rate remains unchanged. But maximal severity on the right reveals a profound difference. Glutamine delays onset and prevents lesions from escalating into critical pain categories. Delaying these symptoms allows patients to continue eating orally much longer. Crucially, it avoids pausing their strict radiation schedule, keeping primary treatment on track. The final domain evaluated by the review is functional status, which tracks physical performance metrics like hand grip strength and mobility. Here, the evidence base is thin. Only 3 out of 20 studies evaluated this domain, producing mixed results that are currently only directionally encouraging. This grid represents the messy reality of the clinical data. When we plot these 20 studies together, we find immediate blind spots. Several trials carry a high risk of bias, suffer from patient dropout, or use inconsistent nutrient formulas. Because researchers used variable timing, differing doses, and mixed cancer types, these findings cannot be pooled into a single undisputed statistic. These blind spots mean the data provides a plausible clinical signal rather than an ironclad guarantee. It requires oncologists to be meticulous with their application. Taking this data back to the patient's bedside clarifies the stakes. Head and neck cancer treatments induce massive systemic catabolism, a rapid breakdown of muscle and tissue that threatens a patient's survival. In this environment, preserving body weight or delaying mouth pain constitutes a significant clinical victory. The evidence collected over the last decade officially moves immunonutrition from a theoretical idea to a functional supportive care strategy. Oncology teams now use nutrition as a proactive strike to maintain a patient's physical trajectory from the start of treatment well before the onset of advanced wasting. There is a final critical caveat. Immunonutrition yields specific results under specific conditions, and the commercial products available are not unilaterally interchangeable. The tactics that prove successful in the audit require using enriched formulas continuously for weight maintenance and deploying targeted glutamines specifically for mucosal defense. The clinical value of these nutrients depends on informed integration rather than unquestioned adoption. When the right compounds are integrated into a treatment plan, oncologists and their patients have access to a proven biological shield during the most difficult phase of treatment.